classifications of inflammation. Bingo, acute and chronic. It's as simple as that. Let's go into the concept of neoplasm now, okay? Also defined on a cellular basis. A benign neoplasm is a proliferation of cells in which there is no infiltration of surrounding or remote structures. A malignant neoplasm is a proliferation of intrinsic cells which there is infiltration. So if you want to know what the difference is between a benign and a malignant neoplasm, it's simply one word, infiltration. And believe it or not, this question almost always appears even on the pathology board exams. That's how important it is. It might seem simple to you, but it is of tremendous importance. So let's say, for example, that there's such thing as benign and malignant. I know what you're going to say. You're going to say, well, isn't there something that is like pre-malignant or dysplastic or atypical? These are words that we use, which are borderline. Yeah, and that's what we call either pre-malignant or atypical or dysplasia. Now, I don't know if you remember what a squamous mucosa looks like, but this happens to be the one that covers the cervix. You might think maybe it could be a bronchus, or maybe it could be an esophagus or oral cavity or even a skin. But these are cells that are bigger, darker than some of the surrounding cells, and you would call this in the borderline zone. And even though the surgeons and you will always ask the pathologist, is it benign or malignant? Well, we're going to say, well, you know, it's kind of in between. And that's what gives you great anxiety, because you don't know what to tell the patient. But what you will do is keep a close eye on it, or maybe even do some surgical procedure. Now, here is a breast. You're going to have to trust me on this. It could be any glandular organ in which you see some fat, and then you see some ducts. But now you see that some of these little epithelial or ductal structures have infiltrated into the surrounding fibrous tissue, and they don't belong there. So this is a neoplasm in which they're a malignant neoplasm. It's a neoplasm that's epithelial. It's a neoplasm that is kind of glandular, in that these little nests look like they're circular little clusters of cells. So we could call this an infiltrating glandular neoplasm. And of course, another name for that is adenocarcinoma, okay? So once again, here's your next test question, and I know you're going to get it right. And it's going to be, what are the two primary morphologic classifications of neoplasms? Bingo. You know which two you're going to pick out. Benign, which is non-infiltrative, and malignant, which is infiltrated. And I'm sorry if I can't answer all of your questions as soon as you write them, because I'll kind of look at them during the break and maybe make a comment about them. So if you expect an immediate answer to your questions, I should probably have another guy here riding shotgun who could answer them. Okay, let's talk about this third classification of diseases. We talked about infiltration by inflammatory cells. We talked about proliferation of cells. Now we're going to talk about loss of cells. And the concept of degeneration, basically, as one word, could be called cell loss. Actually, that's two words. So if you look at some of the degenerative diseases like arthritis, for example, or maybe atherosclerosis, which are classically called degenerative processes, they're generally associated with aging or hormonal involution, or loss of the structures which keep cells healthy and multiplying, or loss of cells due to other reasons. But these are all of the processes which are generally associated with degenerative diseases, like aging, hormonal involution. A good example of that would be why in your anatomy lab last year did all of the thyroids in these older people look so small? They weren't as big as the books say they should be. Well, that's because sometimes aging is associated with hormonal involution in both sexes, atrophy or hypoplasia. So once again, we're going to ask you, Test question number 4, because I know you got the first 3 questions right. What are some of the primary processes associated with the cell loss, or what we call degeneration? And look, it looks like there's a lot of things here that you might want to pick out. There's probably going to be more than 2, but the answer is aging, atrophy, hypoplasia, which we will define in the next webinar, but it's basically a lack of cells, a fewer number of cells due to a wide variety of reasons, normal and abnormal, and hormonal involution. You know that these items here are not associated with degeneration. Okay, when I taught the PATH course at Scholl for a few years, Dr. Schneider taught the PATH course at Rosalind Franklin, or Chicago Medical School, and I would be very, very active in the histology lab, showing students normal histology. And then the next year, those same students in their second year would go to Dr. Schneider for his pathology course. And one day he saw me in the hallway, and he asked me a question. He said, "John, why do all these students completely forget their histology?" And you know what? That is a very valid question. Maybe they didn't like the course. Maybe it was too complex. But I know the answer now after many years. And the reason why Dr. Schneider's question, why do people forget histology and therefore do not have a good basis for histopathology? The reason is because they are too damn occupied learning the names of little cells rather than actually looking at the whole big picture. In other words, they can't see the forest for the trees. Now, I just got a little pink thing on here, which you probably see. It says you may be experienced bad audio quality. So I'm going to ask you to ease my anxiety. Can you still hear me well? Most of the time that flag goes up, it's a false flag. And everybody's saying yes, so I'm very happy. So that's the answer to Dr. Schneider's question. You're too interested in learning the names of all those damn little cells rather than looking at the big picture. Okay, so what does normal histology means? It means you look at something, like you look at a face. Maybe the face looks normal. Maybe the face is not normal. But what does all this mean? If you, in your mind, can recognize normal major organs, which we're going to do in the lab today, like liver, like kidney, like lung, like heart. If you basically forget about the damn names of the cells, just look at them and you say, yeah, that's a normal lung. Then this normal lung is infiltrated by either polys or neutrophils, then you would call that an acute inflammation of a lung, or an acute pneumonia, or acute pneumonitis. If basically, for example, the cells are mononuclear, like lymphocytes or macrophages, then you might call that chronic inflammation in the lung, chronic pneumonia, let's say. If the cells that are parts of the histologic structure are increased or proliferate, then you would think this could be a neoplasm. If they proliferate to the degree at which they infiltrate surrounding tissues or even metastasize, then it's a malignant proliferation. Okay? If you see that some parts of the normal histology has a loss of cells, like you look at a bone and the articular cartilage is eroded, or the cartilaginous cells are lost, okay, that would be a degenerative disease. And that's the easy thing I want you to keep in mind. And once again, I have my little chart holding up in front of my face right now, and I want you to conquer your fear of histopathology. There's not ever going to be a lot of histopathology on the STEP exam, but it's much more important that before you whip out your prescription pad and start writing for things to make big pharma rich. I want you to have a visualized idea of the cellular changes that you are treating with your prescription pad, okay? Now, this was part of our routine histo lab schedule. And remember, all of the pictures that I show you now are either going to be normal or basic disease patterns. So in the second half of our histo lab schedule, we looked at the urinary system, the lymphoid system, blood and bone marrow, lung, cartilage, bone, blood vessels, brain, and skin. Now, I'm going to show you pictures of normal things here. And then I'm going to show you some patterns. Now, remember, this is going to be pictures that I have made already. But after we take our break, we're going to get real slides and look at real normal and abnormal tissues as well, depending on, and I have a bunch of them here, but it'll be, let's see, probably be on the basis of, let's see if I could get rid of this thing. Okay, we closed it. So these are going to be the slides that we have in our slide boxes for the second half. And if you see something that's called APP-itis, then you're probably going to think maybe he's going to show us an acute appendicitis. Okay, so here we go. Let's take a look and keep in mind that a visual feel for the tissue is much more important than remembering the names of all the goddamn cells. Okay? It's like if you are in a airport and you see your Uncle Joe, okay, you don't, and you're looking around at people, you don't have to say, well, that's Uncle Joe because he has blue irises and he has a dimple on the left side. You say, no, that's just Uncle Joe. That's temporal lobe. That's pure pattern recognition. So forget the names of the cells. If you want to remember them, that's okay. But remember, look at the pattern recognition and then say, oh, well, Uncle Joe has measles. So there's spots all over his face. Then you're going to be understanding what histopathology like, and you'll be losing your fear. That's a normal kidney. Now, I think you're going to go, oh, kidney, man, I can't remember all of the stuff there. Well, if you remember that there's a bunch of little glomeruli, which you see already, and then there's tubules. That's basically all you have to do, and blood vessels. So if you go into the textbooks of pathology, you'll see that there are diseases of glomeruli, diseases of tubules, diseases of vessels, and then you got a cortex out here, and then you got medulla here, which is chiefly the tubules or collecting ducts, whatever. So you don't have to remember, what mesangial cells are inside of a glomerulus. Just know that all these little spotted little things are glomeruli, so you must be either in the cortex or in the renal columns. Okay, and if you go higher, you're going to see both glomerulus, tubules, and big blood vessels. In this case, it looks like it's a pretty good size artery. So, and you don't have to remember the 3 or 4 different types of cells you might see in a glomerulus. Okay, just bingo, pattern recognition. Anybody should know, even if you flunked histology, that that's instantly a kidney, mostly by recognition of a glomerulus, okay? And if you want to go further then, you could say, well, look, this looks like a glomerulus, but it seems like there's a lot more cells in there than I normally see. Bingo. You don't have to say what kinds of cells. Say, well, let me think. Glomerulus, an increased number of cells infiltrating the glomerulus. Maybe they look like lymphocytes or macrophages. That must be some kind of glomerulonephritis. Well, that's how your mind should be thinking, okay? And let's take a look now at another kidney. And you can see, it's kidney instantly because you see a glomerulus here, you see tubules here. But look at, what are all of these little tiny, tiny cells? They look like they're tiny mononuclear lymphocytes or maybe acute inflammatory cells. Where you go, well, if you have inflammatory cells inside a kidney, especially the tubules, then that must be pyelonephritis. Bingo, it's that simple. Now you got a kidney again. In this case, you're seeing mostly tubules, but you can see that these smaller arterial blood vessels like here and here are a little bit narrowed. I think that when you see a blood vessel and it's almost has a very tiny lumen, that's narrowed. So what's another word for narrowed? You could say stenotic. And if you find out that it's narrowed because the wall in it is thickened, you could say, well, that might be a disease that somebody would call nephrosclerosis. Okay, one of the most common findings in almost all types of hypertension. Okay, bingo, let's move on. And I know you're going to say, well, why is this thing not in pink and blue, hematoxylin and niacin? That's because it's not important. What you are seeing now is some kind of structure in which looks like there's little clusters of follicles towards the cortex, and then there are these little whiter channels towards the medulla, and you see that these whiter channels are also right underneath the capsule too, and that is the way you should always think of a lymph node. This is the world's most normal lymph node, and you don't have to remember the parafollicular zone and this. You should just remember that you have the follicles in the cortex and these open channels called sinuses in the medulla. Bingo. And you also know a lymph node should not have any epithelial cells. It should be all lymphoid cells and fibroblasts and blood vessels. So what would happen, let's say, if you saw a glandular epithelial looking cells anywhere in a lymph node? Say, well, it must be metastatic carcinoma, right? Or let's say that you saw that you got follicles here, so it must be a cortex, and this must be the fibrous tissue or the capsule of the lymph node. So this whiter area might be something called a subcapsular sinus. And the reason why a subcapsular sinus is important is because if you remember the flow, from the afferents to the efferents, that the first cells to drain inside of a lymph node basically would come into the subcapsular sinus, including metastatic cells. So when a pathologist examines lymph nodes and he works hard and he tells the family that the lymph nodes were all free, it means he paid special attention to the subcapsular sinus if it didn't look like there was a lot of tumor anywhere else. Here is a situation in which you have a prominence of the follicles. They're bigger and they're more numerous, and this is the cortex. So this might be a type of reaction in a lymph node, which you could call follicular hyperplasia, okay? And that doesn't mean it's malignant. It just means that this lymph node is reacting in its follicles to maybe some type of stimulus. It could be a whole wide variety. Here's another lymph node. Remember, we said follicles in the cortex, sinuses in the medulla, and you can see that these sinuses now look a little prominent. So you say, well, this is a prominent sinus. Well, if you still have the follicles on the cortex and the sinuses are prominent, that's probably going to also be another type of benign reactive situation. Okay? And of course, we all said we're going to realize instantly that any epithelial or glandular structure, even if you have to prove it by doing epithelial or glandular markers, is inside of a lymph node, that's going to be metastasis. Now, look at this. This is a lymph node too. But now the entire lymph node looks like this. So you don't have follicles on the outside and sinuses on the inside. What if I told you the whole lymph node looks like this? But on the other hand, they still look like lymphocytes. So if you have a lymph node in which the normal, follicular sinus architecture is replaced by monotonous, uniform-looking cells, even if some of them are spotted with other cells, and they're not epithelial cells or glands, then maybe this is a malignant lymphoma. And I'm sorry for using the redundancy, because all lymphomas are malignant. And if you were a creative guy, like, I'm trying to think of the guy's name, and you thought that these were all stars in the sky, and you want to say, well, look at all the stars in the sky. Well, this is a commonly used term to describe a particular malignant lymphoma known as Burkitt's lymphoma, caused by a virus, and we'll get into it a lot more later. Okay, here's a bone marrow. And you know, when you look at a bone marrow, it's like flying in an airplane. You have to go through a checklist of normal features. In other words, are all the cells heterogeneous? Do you have big cells, little cells? And then you say, could you see the maturation of the red series going as the nucleus gets smaller and denser, and also the maturation of the granulocytic series, where you go from basically blast to mature polymorph nuclear leukocytes? Is there a normal number of lymphocytes? Is there a normal number of plasma cells? You know, no more than, let's say, 10 or 20%. Is there a normal number of cells which you can't really identify because they're primitive or blasts? Maybe just a few percent. Do you normally have iron inside of the bone marrow, which you should have? Or are there any foreign or metastatic or, once again, epithelial cells? Because the bone marrow should not have any epithelial cells. So if you see a gland inside of a bone marrow, I can promise you, even if it's only one gland, it's metastatic. Now, here you have a bone marrow, and it's not 50% fat, which normal adult axial bone marrow should be, but it's 100% cells. And it doesn't take a rocket scientist to remember from your basic histology that the vast majority of these cells look like plasma cells, where they have an eccentric but round nucleus, an oval cytoplasm, and I don't think it really, you don't really have to look at too many plasma cells to realize that this bone marrow is almost all plasma cells. So you would call that a uncontrolled proliferation of plasma cells, also known as multiple myeloma. Okay? And if you didn't believe they're plasma cells, you could look closer or do special stains. And almost all these cells have the classical feature of a plasma cell. It's an oval cell with a round nucleus off to the side. The chromatin tends to condense in a spotty fashion at the periphery of the nucleus. And there's a little clear zone in the wider lip of cytoplasm. These are all the classic features, the 4 classic features of a plasma cell. And if you can name a cell that has all 4 of these features, it is absolutely a plasma cell and nothing else. Okay, I know I'm going into a lot of normal and trying to tip you off into the abnormal, and we're probably getting into the home stretch here. But look at, what is this? Well, it's a normal lung. The normal lung has 3 kinds of holes: the alveoli, the bronchi, and the blood vessels. The blood vessels, whether they're arteries or veins, are usually filled with blood. The bronchi are filled, lined by epithelial cells. They may be columnar or cuboidal. If they're big bronchi, you may see cartilage as well. And then you see most of these tiny walled spaces are alveoli. And I know you remember from histology, there's the alveolar ducts and the alveolar sacs. Well, forget that bullshit, okay? When you see a tiny thin-walled structure in the lung, that's an alveolus. So you got your bronchi, you got your blood vessels, you got your alveoli. Make it that simple for you, because all lung diseases are going to show some kind of change in one of these or another. For example, you know this is a bronchus again, or bronchiole, because it has a pseudostratified ciliated columnar epithelium, but there's no cartilage. So you could call it a bronchiole rather than a bronchus. You can see a blood vessel out here, thick-walled, probably branch of the pulmonary artery. And then you can see these tiny little spaces, or the beginning of them, probably an alveolus or something very close to it. And of course, the alveolus is not lined by cuboidal or columnar. It's lined by a very thin squamous type of epithelial cell called a type 1 pneumocyte. Now, you got the same lung, and we're looking at an alveolus. And you look inside the alveolus, and it's disrupted by these cells. And if you look closely, I think I could convince you most of these cells are neutrophils. And if you don't believe it and you think I should go higher power, we will go higher power in the second hour, okay? These are actually inflammatory cells disrupting the alveolar architecture of the lung. So by definition, you know you can call that acute pneumonitis or acute pneumonia. Okay? Here is a squamocolumnar junction. Well, could this be the cervix? Could this be the esophagus? You know, there's 3 squamocolumnar junctions. Could this be the anal-rectal junction? And actually, I think this is probably the esophageal gastric junction. But you know that a squamous membrane should be multiple layered cells, and a glandular mucosa should be basically columnar epithelial cells. So what would happen, for example, whoops, actually I'm not going to show you any abnormal features, but what would happen if these cells proliferated and infiltrated? Well, that would be a squamous cell carcinoma, wouldn't it? What would happen if these columnar epithelial cells proliferated and infiltrated? That would be an adenocarcinoma. What would happen if these cells here were infiltrated by inflammatory cells? Well, that might be an inflammatory process at the gastroesophageal junction. What would happen if these cells became inflamed? Well, that might be a gastritis. If these cells were disrupted, that might be an esophagitis. And finally, what would happen if these cells here were lost or became thin? Maybe you'd call that gastric atrophy. So you see, this is, even though I'm not going to show you diseases associating with these squamocolumnar junctions, I think it's a good example of the basic patterns of common diseases. Here's a bone marrow again. Look, you got bone, you got spicules of bone, you got marrow inside of a bone. And remember, even though it's bone marrow, half of it is fat. In the appendicular skeleton in an adult, the bone marrow is 100% fat. In the axial skeleton of an adult, the bone marrow is about 50% fat. So if all of a sudden you have 100% cells, you know that cells are proliferating, perhaps in a benign or malignant fashion. If you had a 0% cellularity, if the axial skeleton had all fat, you might think, well, maybe this person was exposed to radiation or chemicals or something which wiped out his bone marrow, which of course could produce an anemia, a granulocytopenia, and a thrombocytopenia. Okay, that's the general principle. Oh, and this one, we see normal bone with some marrow, and then we see a cartilaginous cap. Let's say that this was an articular surface of a bone, like a hip or a knee or a finger, and you had loss of these cartilaginous cells. Hey, you might say, well, that's a degenerative process. If you have a loss of cells, well, that would be called degenerative arthritis. It's as simple as that. I think I have about 3 more pictures, or 4 or 5. Yeah, here we go. Here we have erosion of the articular surface. That's a classical thing you might see. And then, therefore, weakening of the underlying bone. And rather than one bone being interfaced with another bone by virtue of cartilage, if the cartilage is lost, the bone might communicate with the other bone directly with no cartilage buffer, producing a lot of pain, okay? Van, do you remember from gross anatomy, your van? The veins, arteries, and nerves run together. Well, there's a vessel where the wall is thick. That could be called an artery. There's a vessel next to it where the wall is thin and wobbly. Though in arteries, the wall is so thick, it actually produces a round lumen, okay? In a vein in which the adventitia is the thickest feature, it's collapsible. But in an artery, the thickest feature is the muscularis. So you don't have to remember all the cells' names, but you should remember the endothelial part, or the intima, the muscular part, and then the connective tissue adventitial part. And that, of course, is a nerve that's running with it. So once again, I am not going to assume that you all remember exactly everything or got A's in histology. But I think I should assume for the average person at this webinar that they can at least recognize these as blood vessels and, maybe a nerve too. And these are the things that you might have been picking out of your dissection last year, and you're wondering if it's a nerve or an artery. Well, if there was blood inside of it, it wasn't a nerve, was it? Okay. Here's another collapsible vein and a bigger artery next to it. And there's the lumen of the artery. You can actually see some blood. Here are some more blood vessels in which you see narrowing and asymmetric narrowing and perhaps even some clot formation. So this is some type of process in which we have accumulation of material within the artery producing a small lumen. And of course, you probably already know that the most likely thing to do that would be atherosclerosis. And if I asked you right now to say what percentage of this blood vessel is lumen, you might say 40 or 50. If I asked you what percentage of this blood vessel is lumen, you might say 20 or 10, maybe 30. Well, if you were a cardiologist or a radiologist doing angiography, you might give that same exact number only by virtue of looking at it with dyes or, let's say, MRI, rather than looking at the actual real cross-section. Okay, now you could tell part of a big blood vessel, and then you have something, a big blood vessel, maybe a big artery, and now you have the blood inside. But you have to ask yourself, is this blood like a clot? In other words, organized? In other words, part of the actual blood vessel? Or is it just something that was present inside? So this is a problem often both microscopically as well as grossly. But if you do an autopsy or you do your anatomy dissection and you see blood inside of a vessel, usually a big vessel, and it does not peel off easily, then it's probably just a real blood clot if it's fixed to the wall, rather than just blood that happens to be in it post-mortem. So that's the difference between a pre-mortem and a post-mortem blood clot. You might remember this as looking like connective tissue. And you could see fibers, and you could see cells. And if you went bigger, you could see not only cells, but you could see striations on these cells. So, that's striated muscle. And the striation and the nuclei are not at the periphery of the fibers. The nuclei are generally in the middle of the fibers. So you say, well, that's striated muscle in which you have the nucleus in the middle and the cells actually crisscross with each other. So that's probably the striated muscle that we call cardiac muscle or myocardium, or 90% of the mass of the heart. This is about as normal as could be. But what if those fibers now were infiltrated by these inflammatory cells? I know what you're thinking. You're thinking, well, this must be an inflammatory disease of the myocardium, maybe a myocarditis. Well, it could be, but remember, when cells die because of an infarct, that necrotic tissue also evokes an inflammatory process. So this is might be called an acute or recent myocardial infarct. If you technically wanted to call it a myocarditis, second to the presence of necrotic myocardial fibers evoking an inflammatory response, you could do that too, but everybody will laugh at you, okay? And now here we have some more myocardial fibers infiltrated by chiefly neutrophils. So that is a classical acute, probably transmural, because it involves perhaps the entire thickness of the myocardium, acute or recent myocardial infarct. And here's some more myocardial cells. If you look closer, you can see striations. But now, rather than inflammatory cells disrupting these fibers, you have scar tissue, you have fibroblasts. So you have fibroblasts and collagen down here and myocardial fibers up here. That's scar tissue within a heart. So that might be an infarct that you would call old or remote, but not acute. That might be somebody that had a heart attack, 30 years ago. Now I am really near the end, I promise you. The central nervous system has always feared the most because it's the most complex system in the brain. But I got news for you. If you remember that the central nervous system, no matter where you are, no matter what little part of the brain, no matter what it's called, whether it's gray matter or white matter in the pons or in the cortex, they basically have only three kinds of cells. You have these bigger cells called neurons. You have these smaller cells called glial cells. And you might have these little spaces called blood vessels. So that's what I like about central nervous system. Lose all your fear about what the clinical symptoms may be. Lose your fear about what parts of the scan it's on. Lose your fear about what the name of this little structure could be. Could this be the locus ceruleus, And just say, this is normal central nervous system tissue. Now, in here, you do not have normal central nervous system tissue. You see infiltration of a lot of these cells. They look like they're inflammatory cells. So would you call that maybe an encephalitis? Or would you maybe call it necrosis? Because once again, necrotic tissue evokes the presence of infiltration of inflammatory cells. And of course, in the brain, the chief inflammatory cells are the glial cells or the microglial cells. What if you had looked at a brain and rather than saying big cells, little cells, and blood vessels, you saw that all the cells generally looked kind of monotonous, but some of them were bigger and darker, much bigger than other cells. I mean, say maybe this is a brain tumor because you're having not only a proliferations of cells, but these cells do not look like each other. So maybe this is a primary tumor of brain. And if they were really nasty looking and big and infiltrative, let's say, and causing necrosis, you might say, well, this is probably a malignant tumor of brain. If they were didn't show very much atypia or necrosis, you might say, well, maybe this is a benign tumor. But remember, even a benign tumor can kill you depending on where it is in the brain. Here's a blood vessel in the brain, okay? And look at, in and around this blood vessel, you see a lot of these inflammatory cells. So how would you describe this? Well, if you were an honest person, you would say, this is a blood vessel of the brain that has a lot of inflammatory cells around it. And that's perfectly fine with me because you're being honest. But this is also a picture of a classical acute viral encephalitis. I know I'm throwing a lot of stuff at you, but I promise you we only have 4 more slides. And that's the world's most normal skin. And now you could see the epidermis. And then we use a connective tissue stain to see the papillary dermis. And then there's the reticular dermis. There's part of a hair follicle and sebaceous gland. or what they call the pilosebaceous apparatus. There's a duct from a sweat gland. Okay, that's the world's most normal skin. And guess what? Here's the world's most normal skin, even closer up. Basically, you're looking at the delineation or the basement membrane between the stratified squamous keratinized epithelium and the underlying dermis, and the closest connective tissue of the dermis is called the papillary dermis because it interdigitates with the papillary waviness of the epidermis. And you go, wow. But now you don't see a good junction between the stratified squamous epithelium and the underlying dermis or connective tissue. What you're seeing is proliferations of a lot of cells. And you're probably thinking, well, why do a lot of these cells look so dark? You know, they look like maybe they're pigmented or melanocytes. Well, this is when you start to really, really worry because you are now dealing with the only common malignancy of skin that can often kill you. The squamous cell carcinomas don't kill you. The basal cell carcinomas don't kill you. This is a malignant melanoma, okay? An infiltrative pattern of melanocytes rather than them being contained to the lower levels of the epidermis and maybe sending up a few little granules. They are basically extending now into the dermis. Finally, and this is our last picture before we take our music break, you're looking at skin again. And if you remember when they were describing skin, all the various layers, the basal layers, the prickle cell layer, stratum corneum, stratum germinativum, all these different things, which you could remember if you want. You might have remembered that the so-called basal layer, okay, or stratum germinativum, had cells which looked like they were kind of palisaded, in other words, standing up in a row. And now you got a tumor that's arising from this basal layer, which, look, it also has this kind of linear palisading is the word. When they all look like they're standing up next to each other like little soldiers, it's called palisading, okay? So if this tumor is arising from the basal cell layer, which of course is the most mitotically active layer, the layer of the skin that you think might have the most common types of tumors would be the cells of the epidermis that normally turn over the quickest. This is a basal cell carcinoma. This is the #1 tumor of the skin. Common, it's malignant, but it doesn't invade and it hardly ever kills. And of course, you can also have a squamous cell carcinoma as well. And you can also have tumors of the occasional melanocytes proliferating in an uncontrolled fashion. That would be a malignant melanoma. But wait, let me ask you a question. In fact, I think because this was our last slide, I deserve to ask you a question now. And I don't want to embarrass anybody. I'll be reading these questions, but I want to see somebody tell me, what does the squamous cell carcinoma, basal cell carcinoma, and malignant melanoma all have in common? No answers. It's because you got to think real hard. Well, what they all have in common is that they're all caused by sunlight. Okay, they are all, their development depends on the amount of sun exposure. Okay, so people that don't have much sun exposure have a low incidence of all three of these common skin malignancies. Thanks for answering anyway. I'm going to ask one more question because at one point in here, somebody asked a question that they couldn't hear well. And I then asked everybody if they could hear well. And a lot of people said, yes, we can hear well. So my question to you right now is, did everybody hear me well and continuously in the first hour? And even if I see a couple of yeses, I'll be happy, because if some people didn't hear me well, I can rest assured that it was their side that had the problem rather than my side. And I just love to show examples of where things are other people's fault rather than my fault. So that's our presentation for today. We're going to come back after the music break, and rather than show you these stupid little pictures, we're going to actually show you a real microscope view where if you wanted me to blow up this area to show you palisading, that I could do it. Because we're going to be using my real virtual microscope with real glass slides in a real histopathology lab. Whoops, how do I get rid of this stupid thing?